Good afternoon, everybody. We'll go ahead and get started. Stay close together. The room is cold, so breathe heavy and stay warm. It's my pleasure today to introduce again Dr. Ann Eshelman. Dr. Eshelman is the director of our transplant psychology program, and she's been a leader nationally and locally in management of patients with liver disease and other transplants as well. And has been recently also a co-presenter with Dr. Venkat on the controversial or ethical dilemmas in living donation. Today we're going to talk about the context of patients with fulminant liver failure from acetaminophen. This is a very complex area, both from the medical standpoint as well as the psychological standpoint and social support. And hopefully we can engage in a good discussion from those case presentations. Ann, thank you.
Thank you. Thank you, and welcome. Today our goals are to understand acetaminophen overdose, intentional and unintentional, and look at what happens after somebody overdoses. So we'll be talking about two cases that have happened here at Henry Ford Hospital. The first one I'll call Jennifer, not her real name, 26-year-old mixed-race woman who ingested 150 Tylenol PM gel caps with a cup of NyQuil, brought to the ED by a friend 17 hours after ingestion. So what is acetaminophen? We know it as Tylenol, but it has other names. In Britain, it's paracetamol. It's a very common analgesic, and it's safe in therapeutic doses. It's the active ingredient found in more than 600 over-the-counter and prescription medications, so that many people don't know that there's Tylenol in something or in some compound, and they think of it as a very benign substance. But it's found in pain relievers, fever reducers, cough suppressants, and cold medicines. More than 8 billion capsules of Tylenol are taken each year. These are some of the brand names, and again, it doesn't jump out as acetaminophen. You don't have to read them all, but just sort of to show you. When you look on the website RX List, the top 10 most popular drugs listed, 2 of them, Percocet and Vicodin, are combinations of acetaminophen and opioids. So how common is overdose? 60,000 overdoses of Tylenol each year, 26,000 resulting in hospitalizations, and 450 to 500 deaths each year. It's the most common cause of acute liver failure in the United States and in the United Kingdom, and accounts for 40% of all overdoses. So what happens with an overdose? 10% develop severe liver damage, and a very small number develop acute liver failure, which is characterized by hepatic encephalopathy and coagulopathy without a history of liver disease. So who overdoses on Tylenol? Most of them are women, Caucasian, with a median age of 36. So what happens with acetaminophen hepatotoxicity? Actually, we've got people in the audience who know more about this than I do, but basically there's a toxic metabolite which depletes the liver's natural antioxidant, directly damaging the liver. Let's first talk about intentional overdoses, and that is a suicide attempt where somebody takes an overdose of Tylenol with the objective of self-harm. And in different studies, they have different breakdowns of what percentage are intentional or non-intentional. But in one study, the range was 27 to 40%, 44% of overdoses are suicide attempts. And this is defined as a single dose overdose of more than 4 grams at a single time, or a staggered overdose. And that can be somebody taking an overdose one day and then also the next day, or over a period of time. We also look at a mixed overdose, and sometimes when people attempt suicide, they go in the medicine cabinet and they see what's there. And there may be Tylenol, there may be aspirin, there may be antidepressants, there may be all kinds of things. A compound overdose is when it's a medication that's a compound of acetaminophen and something else, like Vicodin, Percocet, those kinds of things. So what does the presentation look like after an overdose? These are the 4 phases, and as you can see, phase 1, early on in the first 24 hours, the patient has symptoms that would let them know something is wrong. And if somebody doesn't get help during this time, when they have the pain, nausea, vomiting, lethargy, if they or their family doesn't notice and get them some medical help, they're specifically avoiding treatment because they know something is wrong. In the phase 2, however, the symptoms may improve and some of those symptoms may go away, but then they may get worse again. Looking at acute liver failure, it's basically a severe decline in hepatic function, and most people who don't work with liver patients or don't really know what the liver does. And the liver does a lot of really important things. So when there's liver failure, you get lots of systems shutting down. Acute respiratory failure, and these patients may be intubated. They may have severe coagulopathy with bleeding everywhere, with many transfusions. They may have acute renal failure because of the liver failure, and basically multi-organ system failure, and hepatic encephalopathy, which is confusion ranging to coma. 80% of people with acute liver failure grade 4 have cerebral edema, swelling of the brain, and increased intracranial pressure, and this can be a major cause of death in this population. These are the grades of hepatic encephalopathy, so that patients may come in grade 1 with some minimal changes in consciousness, but may progress to coma and may fluctuate. So what do you do with acute liver failure? In the first few hours, you try to get rid of the Tylenol with gastric lavage, activated charcoal, which absorbs, and Ipecac, which induces vomiting. That only works with immediate, early. Up to 10 to 16 hours, what's used is this NAC, N-acetylcysteine, which is a precursor of glutathione and helps the body regenerate, protects against liver failure, renal failure, and death. And the outcome makes a big difference whether or not the patient got this NAC. So back to our patient Jennifer. She was admitted 17 hours after ingestion to an outside hospital with a Tylenol level of 140. She was transferred to Henry Ford on day 3 for management of acute liver failure and possible liver transplant. At that point, her Tylenol level had gone down to 75. These are some of her labs on day 1, and as you can see, all of her liver function tests were very elevated, and her prothrombin PT was very deranged. Her treatment, she did get charcoal, she did get NAC, but it didn't start until 17 hours after ingestion at the other hospital. She was intubated, sedated, paralyzed for elevated intracranial pressures. She had acute renal failure and was on hemodialysis. She was tachycardic, moderate pulmonary edema, and she had coagulopathy. She got 11 units of blood transfused on the first day. So at this point, the issue of liver transplant comes up, and we look at medical issues, surgical issues, and psychosocial. When someone's evaluated for a liver transplant, our goal is to, from a psychosocial perspective, our goal is to identify issues that may interfere with post-transplant success. And our question is, how can we safely and successfully get the patient through the process? Some questions also come to mind. Who can benefit from a transplant? This is a scarce resource. There aren't enough livers to go around, and 60,000 people die of liver failure each year. And on waiting lists across the country, about 10% of those waiting for liver don't make it to transplant. So we have to be very careful about who should get a transplant. This is an outline of our psychiatric evaluation. We do the psychiatric and chemical dependency. Again, our goal is to identify and treat, not to exclude people. Not a thumbs up, thumbs down, but can we safely get this person through it? So we look at psychiatric history. In the context of a suicide attempt, We want to know, have they had previous suicide attempts? What is their baseline psychiatric condition? Have they accessed treatment before? Have they been non-compliant? That's very important in being able to predict, are they at risk for another suicide attempt? We look at cognitive screening, although these folks come in and we can't really assess them. We may be just seeing somebody in a coma or unable to sustain attention. But we want to get information about what their baseline is. So we want to know, do they have a learning disability? Do they have, what was their level of functioning? Were they working? Were they paying bills? Were they taking care of business? Or were they at some marginal level of functioning prior to this? We also want to know their substance abuse and use history. Is this in the context of substance abuse, or is this someone who out of the blue had a suicide attempt? With substance abuse, we have guidelines for abstinence and relapse prevention. Patients who come in a coma don't do well in Teresa's group. We look at social support too. Who's there for the person? And also, can they access the social support? So when somebody attempts suicide with a serious suicide attempt like this, even if they have people who are important to them, they didn't call them. They didn't ask for help. And that's important to look at as well. We'd like to know their motivation for transplant. Are they willing and able to do what's necessary to make a transplant work? We may have to ask the family or their friends or whoever's at the bedside, would they want a transplant? Would they be able to do what's required? And with any surgical procedure, we really want informed consent. And if our patient is in a coma or unable to sustain attention, they may not be able to give informed consent. We would like to have an advance directive so that they tell us who is going to make a decision for them, but many times we don't know. The patient just gets flown in or ambulanced in, and they may be alone. So these are some of the requirements for transplant success. This is different from some other medical procedures where if somebody needed an emergency C-section delivery, an emergency appendectomy, basically you take care of things and then they recover and they're on their way. As you know, with transplant, they're required to be actively participating in their medical care the rest of their life, whether it's surveillance of things like infection, whether it's compliance with medications and clinic visits, clean living and healthy lifestyle. And basically giving consent for a transplant is not just I'm giving consent for this procedure today, but I'm giving consent that I will do everything that's necessary to make the transplant work. And we can't tell them exactly what's on the list that they're agreeing to because we don't exactly know all of the bumps in the road that they may have. But they have to feel like they are trusting the team, working with the team, and that their goals for survival are perfectly aligned with the transplant team's goals. These are some contraindications for transplant based on psychiatric and chemical dependency issues. There aren't any standard criteria across the country, and selection criteria vary by center. But if somebody's unable or unwilling to manage their post-transplant care, if there's active substance abuse or dependence, a history of noncompliance, refusal, leaving against medical advice, these can all be contraindications. And a history of suicide attempts. Does it make sense to give somebody a liver transplant if they have attempted suicide before? And, are they going to attempt suicide again and basically waste the liver? If they are saying that they are still suicidal and they wish they had not wakened up and they wish they had died and they want still to die, maybe it doesn't make sense to do a transplant. There are other contraindications in terms of other serious psychiatric illnesses or dementia or retardation if they're not able to do what's necessary to make this work. When we see a person who's being evaluated for fulminant liver failure, we have challenges in how we can get this information. So we may not be able to do the evaluation that we do with an outpatient who comes into our office on case 16. They may be encephalopathic, they may be intubated, the patient may not be able to participate or consent, and we end up trying to get information from whoever we can. It may be whoever happens to be at bedside. It may be family or friends. We may get outside information if we can. We may be making phone calls, but it's hard to get a clear idea of how accurate is this informant, how close are they to the patient, and the family may not know answers to some of these questions. Some people who are alcoholics are quiet and they don't tell people how much they're drinking, or they're secret closet drinkers. Family members also may be really motivated to withhold information because they know a decision is being made about transplant, and if they present the patient in a negative way, it may impact decision making. And they may not know what the patient would want. They may know what they want for the patient, but they may not know what the patient would want. Also, when we think of a suicide attempt, whoever's at the bedside is probably highly emotional and extremely stressed. They may feel guilty that something they did was a trigger for the suicide attempt. They may be in shock. They may be angry at the person. You know, why did you do this? Why did you do this to me? There may be fear, and there should be fear that the person could die, because at the time that we see them, we don't know which way it's going to go. In the context of all of this, there's a tremendous time pressure to be able to list somebody for transplant. So we have to get the information to the best of our ability as fast as possible. So back to Jennifer. This was a serious suicide attempt. She really wanted to die. When somebody attempts suicide, there are two different ways of looking at how serious it is. One is how medically serious it is, and certainly when somebody comes in fulminant liver failure, medically that's very serious. But we also look at, is the intent serious? So that some people happen to grab one medication or another, and that affects how serious medically the suicide attempt is. And some people end up thinking of Tylenol as a pretty benign substance, and they were trying to communicate something to somebody. They didn't really want to be dead. So we have to sort things out and try to look at, was this a serious attempt in terms of intent? She wanted to die, and it was serious medically as well. She was intermittently awake, but when I was able to talk to her, she wanted to live. She had a 6-year-old son. She was able to talk about the trigger event, which was a recent breakup with a boyfriend, and the stress of being a single parent. Her son had attention deficit disorder. She had no previous suicide attempt. Her past medical history, she really didn't have any. And her surgical history was pretty benign, a LEAP procedure of the cervix. Her history, she was a heavy equipment operator in the Army in Iraq and had been back for about 2 years. She was divorced and had a 6-year-old son. She was in community college going to learn how to be a veterinary technician. Her parents were divorced and both were out of state. She did have a psychiatric history. She had a history of depression. She'd been tried on a number of antidepressants. She had side effects from Prozac, and that was stopped. She had a partial response from Effexor, a partial response from Celexa. She had seen a psychiatrist and a therapist at the VA in Detroit until about 2 months prior to this attempt. She did carry a diagnosis of post-traumatic stress disorder after an attack and being raped in Iraq, and then the recent breakup with the boyfriend. In looking at her chemical dependency history, really minimal alcohol, no smoking or drug use. And when we first saw her, it was really unclear what her support system was. Part of that was the person at the bedside was the boyfriend who had just dumped her, and that had been a trigger for the suicide attempt, and her family was out of state. So our impressions, this was a clear suicide attempt, but no previous attempts. She was no longer suicidal and wanted to live. I felt that she had a treatable psychiatric disorder. Actually, the VA is very good at treating post-traumatic stress disorder. They have groups. It's one of the main things that they do because they see a lot of post-traumatic stress disorder. and that the depression was treatable and helping her develop coping strategies to handle the kinds of stress that she was under, I felt that she had a good chance for recovery. We did discuss what kind of psychiatric treatment she would need and looking at would she need inpatient psychiatric treatment. Certainly when somebody makes a serious suicide attempt, they meet criteria for inpatient psychiatric admission. But sometimes we do partial hospitalization or outpatient psychiatric treatment. And both the patient and the family agreed to psychiatric treatment, but it was clear that she was so sick that she wasn't going to be able to do that prior to listing or prior to a transplant. She had a good baseline to return to as far as her education level, her motivation, and her intellectual functioning prior to this event. Her parents came in from out of state, and it turned out that she did have adequate support. Her father was her main support, and while she was deployed in Iraq, he took care of the 6-year-old son and was very much tied into her and the child. She didn't have any history of substance abuse, and although cognitively she was encephalopathic and her concentration and memory were severely affected, her baseline had been good. A CT scan of the head was ordered to rule out brain damage and look for bleeds, herniation, and cerebroedema, which are problems that we see in fulminant liver failure. Actually, this looked pretty good for a CT scan for somebody in her circumstance. So the team discussion included that she was medically and surgically, it was feasible to do a liver transplant. No substance abuse history, no history of personality disorder or difficulty with doctors, no history of noncompliance, and that in the context of all of this, the risk of another suicide attempt was relatively low. Now, the biggest risk factor for suicide is a previous attempt, and she obviously had one, but the other factors made her relatively low risk. So, a question, does she need a liver transplant? In looking at the literature, people in this circumstance, 90% of Tylenol overdose patients recover completely. More than 80% recover even if they do have liver toxicity, if they get the NAC within 12 hours. She didn't get it at that point. If they don't get the NAC, they're less likely to recover. And a small number of untreated patients die within 4 to 18 days. Some of the risk factors for acute liver failure or death after an overdose, the people who do worst are older people, smokers, certain medications, and if they are malnourished. Interestingly, acute alcohol intake can be protective, so in a suicide attempt, if she's drinking an alcoholic beverage and swallowing the pills, that actually can protect her liver. Chronic alcohol increases the toxicity. Predictors of survival are medical care within 24 hours, less hepatic encephalopathy, no cerebral edema, and no severe metabolic acidosis. Her survival risk, she had some risk. She delayed treatment. She had hepatic encephalopathy. She had cerebral edema. Her labs were still very abnormal, and her liver was not recovering. These are her labs day 1, 2, and 3, and as you can see, her liver functions were still markedly elevated, even though the APAP, which is the Tylenol level at the bottom, was back in the normal range at this point. So, can a liver transplant be effective after a Tylenol overdose? Does it make sense to do a transplant? Again, looking at the literature, we've got a number of studies that looked at this question. And although patients with a Tylenol overdose and acute liver failure were sicker pre-transplant than the rest of their population, and 56% of them had a psychiatric diagnosis pre-transplant, 25% had had a previous suicide attempt, but there were no significant differences in acute or chronic rejection, graft failure, or survival rates in this small series of 36 patients. However, 2 out of the 36 later attempted suicide, after the transplant, 1 fatally. Putting this in the context, the base rate for suicide in the United States is 11 out of 100,000. So a suicide attempt rate of 2 out of 36 is astronomically high. Another study by Cooper found no differences in long-term survival rates between those who underwent transplant because of a suicide attempt versus other causes. This is a study more than 10 years in Scotland and looking at transplant for Tylenol overdose. Interestingly, 64% of Tylenol overdose patients also have alcohol or drug issues as well. Their population, they had a very high mortality on the admission when they got the transplant. Although when we look at these long-term studies starting in 1992, there have been lots of advances since 1992, changes in medications, and those series may not be all that meaningful to look at. This is another series of over 1,000 consecutive adults enrolled in the United States Acute Liver Failure Study Group. The first column is the acetaminophen overdose. This is other drugs, unknown, hepatitis A, hepatitis B, and other causes of liver failure. And as you can see, the spontaneous recovery rate for Tylenol overdose is high, higher than any of these other causes of liver failure. 9% of the population was transplanted, and the overall survival rate in this group was 71%, which we've got different causes or different survival rates there. Kahn's study in 2010 looked at 5-year survival rate, and the Tylenol overdose actually population had a lower 5-year survival rate than other acute liver failure patients or chronic liver disease. And the graft survival, the survival of the transplant, was lower than these other populations as well. When we look at these kinds of studies, though, there aren't any randomized controlled trials, and there are no situations where teams decide to transplant every single suicide attempter. So it's hard to say how meaningful these data are. Any reported data is subject to selection, and it's difficult to predict success with any individual. So, question ethically, should Jennifer get a liver transplant? Well, we're looking at ethical issues that we need to address. One is beneficence, or doing good. And we have a duty to protect and promote the health and well-being of patients, advocate for patients' best interests, and that may translate to aggressively pursuing transplant if it's medically feasible. Another ethical principle is fairness or justice, that we need to treat patients with similar clinical situations similarly and not discriminate. And we're sort of stewards of a scarce resource, and keeping in mind that 10% of liver disease patients die on the waiting list. We want to give the liver to somebody who can benefit. Although this isn't always said, it's also good to keep in mind, could we justify our actions to the donor family or to those who die on the waiting list? Some selection issues have come up in the context of this with a suicide attempt. Can they comply with complex regimens? Do they have insight? Is it a treatable psychiatric condition? Do they have current suicidal thoughts? These kinds of things we've already talked about. Was it an impulsive event or a pattern? How severe was the self-destructive behavior? Was it just the suicide attempt, or were there other self-destructive behaviors too? Does it make a difference if somebody is young or if they're responsible for young children? Should suicide attempters be held accountable because they chose to do this and put themselves in this position? And some question, do they deserve a transplant? Should we look at their value to the community, or righting wrongs in terms of somebody who's disadvantaged? Should we hold it against them because they have personal responsibility for their condition? We could have a big discussion about this, but basically the standard at this point is, can they do what's necessary to make a transplant work? And are the psychosocial problems likely to underline the long-term compliance and transplant success? And the UNOS policies are basically the need, urgency, equality, and efficacy. So, psychiatric illness in itself is not a contraindication as long as it can be controlled, although that's hard to predict. Lack of insight, active substance abuse, a total lack of support may be contraindications. What if our patient can't give informed consent, though? And when we see people in fulminant liver failure, they may not be able to give informed consent. And we're asking a surrogate, you know, can you say that this person is going to do whatever's necessary to make a transplant work? In looking at the literature on surrogate decision making, quality of life is subjective, and there are some situations where the person attempted suicide because of chronic pain, and they basically said they didn't want to live in that pain. Would they want a transplant knowing that they'd still be in chronic pain? Some patients or surrogates may opt for palliative care and not for transplant. One study looked at the accuracy of surrogate decision making. So when a surrogate makes a decision, is it what the patient would want or not? And actually the accuracy was only 68%. So sometimes they're on, sometimes they're not. It's better than 50-50, but still that's a pretty low accuracy rate. There's also, when there's a surrogate making the decision, there's a conflict between their interpretation of what the patient would want and what they want for the patient. So the family often says, do everything, even if the patient wouldn't have wanted certain things. Back to Jennifer. She did have an emergency liver transplant 6 days after ingestion, and as you can see, this was a bloody procedure, lots of blood products. She was slow to wake up, slow improvement in renal function, and she was on dialysis for a couple of weeks. She did have a CT scan of the head on day 11 that's shown here. And basically there's the sign of the ICP monitor, but basically she looked pretty good. No evidence of, basically they read it as unremarkable. We followed her as soon as she woke up after the transplant, and we're seeing her daily, helping her understand what led to this suicide attempt, talking about options for treatment, and assessing her mental status. 12 days after transplant, she was awake and alert, and she was mildly disoriented to date and place. During this time, she was learning about her medications and learning about what responsibilities her family had signed her up for. Her labs improved remarkably, so that I have day 1, pre-transplant, post-transplant, and at discharge, and as you can see, transplant works. So we were working on discharge planning from the time of the transplant, trying to decide, did she need inpatient psychiatric treatment, partial hospitalization, did she need a medical transfer to rehab with a psychiatrist consulting? I worked very closely with the VA because that's where her benefits were, and to try to figure out, and each day we were working out different plans. So at one point the plan was she was going to cottage rehab and the VA psychiatrist was going to visit her. It turned out that she was hospitalized for a number of days, and she did end up going home with outpatient follow-up at the VA. We also were working on, was she going to stay in Detroit or was she going to go out of state, which is where her father lived. So by postoperative day 17, she was amazingly clear on a mini mental. She got 28 out of 30. Delayed recall at 5 minutes was 3 out of 3 words, which is pretty good. She also learned her medications and learned what she needed to do to be successful. She was discharged on day 28, and I saw her also on day 30 in the clinic. She was working with the VA psychiatrist, and she planned to return to Kansas with her father and son and get VA psych treatment for the PTSD there, which the VA was helpful in arranging in Kansas. She's had yearly follow-ups to Henry Ford and lab work. She lives out of state. She is finishing school at the last note that I saw, had internships and was doing well with no subsequent suicide attempts. Let's take a few minutes to look at unintentional overdoses, where self-harm is not the aim. This falls into two categories. One is in the context of addiction, and the other they call in the literature therapeutic misadventure. Unintentional overdoses, most of them are related to pain issues and pain management, and it's chronic overuse of pain medication. So some people think 2 pills is good, 4 must be better, I still have pain, how about another one? So what if they say it should be every 6 hours, I can have it earlier? And sometimes people are really sort of writing their own orders. This usually is a staggered dose, so it's not one overdose, but it's an overdose over time. And 38% of these unintentional overdoses are acetaminophen with something else. And when we look at narcotics users, 1/3 of them are taking opioids and acetaminophen in these preparations like Vicodin and Percocet. And they don't really think of the Tylenol part as being dangerous. In therapeutic misadventures, these are mistakes. They happen often with older people, people who are intoxicated, cognitively impaired, and they may be unaware that they're taking more than one Tylenol product. Actually, unintentional overdoses may have higher levels of morbidity and mortality, partly because of delay in treatment. When somebody has a suicide attempt, they take a large dose at one point, and then they come in and they get treatment. A chronic overdose, they may actually come in with a lower level of Tylenol. It may not even be elevated at all, but it's a chronic use over time. How often is this? It depends on your study how frequently it's unintentional versus intentional, and sometimes it's really unclear. We don't really know unless we can ask the person, and sometimes they lie. We'll talk just for a few minutes about another patient here at Henry Ford, a 25-year-old Caucasian man I'll call Jason, not his real name, who presented to an outside hospital emergency department with nausea, vomiting for 5 days, somnolence, and asterixis. These are his labs on admission. He also had his Tylenol level, as you see, is not elevated. He did come up positive for opioids on the UTOX. His past medical history, he had migraine headaches, he had chronic back pain since a motor vehicle accident, and he had had back surgery 6 months prior. This was a list of his admission medications, and actually the rest of the story was that when we did a MAPS on him to look for all the other prescribers, he had 2 prescribers. He was also borrowing Vicodin types of things from friends. He bought things on the street. So what was on his admission medication was just a piece of what his history was. He was actually taking oxycodone, hydrocodone, morphine, Vicodin, and Percocet. He met criteria for pain disorder, opioid dependence, and delirium. He was also a smoker. He had no psych history, no history of treatment, no suicidal thoughts or psychosis. He denied everything. When we asked him about depression, he denied depression, but his family thought he was depressed. He denied alcohol, and when asked about overuse of pain medication, he denied it, but his family thought that he was overusing, and clearly he was overusing, but was not acknowledging it. His father was an alcoholic, actively drinking, and dependence issues do run in families. Also, when we see the father's an active alcoholic, it makes you wonder about what kind of support that person would be for a patient like this. This patient was a senior in college studying criminal justice, and at the time we saw him, he had decisional capacity. His parents were in Florida for the winter, and when we first called them, they were not going to come back to see him in the hospital. And we had to really impress on him, he's really sick, you need to be here. Risk factors in terms of transplant for this young man. He had opioid dependence. He had minimal insight, minimal motivation for alternative pain management. His support system was fragmented. His father was an alcoholic. Sometimes when the patient is in denial or not wanting treatment, we do an intervention where family and friends basically confront the person and say, you've got a problem, you need to get into treatment. Some of you may have seen interventions on TV. But his support system was so fragmented, they weren't able to get together to even do this. And he was a high risk for continued opioid, Tylenol overuse, and noncompliance. He did have respiratory failure and was intubated. He had acute renal failure and was on hemodialysis. His liver enzymes did improve, and a transplant, fortunately, was not necessary. We recommended chemical dependency treatment with relapse prevention and pain management that did not include medications with high abuse dependence potential, and he was discharged on day 12. He did follow up with the pain clinic in our system, so I was able to look at their notes, and they did not want to give him opioids. They wanted to give him a steroid injection, and they did communicate with his primary care doctor to limit the number of preparations he had. They wanted him to do Suboxone detox treatment, but he left during the evaluation when he was told that they wouldn't refill his opioid medications. We haven't seen him back again, but he is high risk for another event like this. So, brief summary. Acetaminophen overdose is common, 60,000 a year, and accounts for 40% of all overdoses. Rapid treatment is vital. Liver transplant can save some lives, and understanding the causes of the overdose and the risk factors is important for responsible and successful transplantation. It's also good to look at what strategies we can do to prevent an overdose. And certainly effective and accessible treatment for depression, suicide prevention is important. Responsible prescribing of pain medication, running a MAPS so that when somebody is prescribing opioids or there's a suspicion of an overuse of opioids, running a MAPS to see who else is prescribing is very important. And I think there needs to be more public awareness of the risks of Tylenol overdose and the prevalence of compounds. In the United Kingdom, they have actually initiated a project using blister packaging, which is basically the pills are individually wrapped and you have to unwrap each one individually like with your thumbnail. So it's hard to take a whole lot at one time. But they found, and they limit the number of Tylenol pills that are in a box to 24. So you can't get a big box of, or a big vial of Tylenol. And it has actually reduced the number of overdoses from Tylenol. Johnson & Johnson has lowered their recommended dose of Tylenol. And there are FDA proposals of labeling changes so that people are aware that Tylenol does have risks, and to limit the dosage to 325 milligrams. There hasn't been any control, and as you can see, some products have way more than the 325 milligrams. And especially when people take 2 instead of 1, if they're taking 2 of the extra strength, they're getting 1,000 milligrams at 1 pop. Any questions? I promised Dr. Albershut I'd be done well before 5, and I made it.
Well, it's such an exciting, in a way, topic because it deals so much with the human mind, not just liver disease. So I wanted to have enough time for discussion. Maybe I can start that with a couple of questions. Do you see a difference between the patients who come in with acute liver failure, but they're alert to where you can discuss the operation, and they agree to doing it, or their family does when they have intermittent awareness, versus those who never engage in a discussion because they were already stage 4 and then undergo a transplant and wake up, partially confused perhaps, to realize that they are in a hospital with a liver transplant?
That's a good question. There aren't any series in the literature comparing the success rates after transplant if the patient was a part of the decision or not. It's a small number, but yes, we have a responsibility when somebody comes in fulminant liver failure and can't be part of the decision to help catch them up on what did their family decide for them. There's also grief and loss issues because they've had to go through a major change from being healthy, and most of these folks are young. So both of my one was 26, one was 25. This is a lot for somebody in their 20s to go through and wake up having major surgery and needing to be on immunosuppressant medication the rest of their lives.
Yeah. Sometimes I see when we're rounding on somebody who had acute liver failure, we're going to use Jones. Miss Jones is waking up. He says, "Good morning, Miss Jones. You just had a liver transplant. Your liver is working." And they don't say a whole lot more. What would you say to the staff, surgeons, physicians, nurses? What should be the conversations that take place when they're coming about? And knowing that they're not going to remember what you said today, although they're looking at you straight in the face. Because encephalopathy is not an open faucet that you close and you open. It's actually brain toxicity, and it takes time to clear and is intermittently connected with periods of awareness and then memory loss and so on. What would you recommend to the staff that they say and do for the entire hospital stay?
Okay, that's a good question. I think it's good to ask questions rather than give lectures, so that asking, what do you remember of what happened when you came to the hospital, and see what pieces they do remember, and then sort of help fill in the blanks. And they may not remember much at all. Some of that amnesia is a very positive thing. Their family remembers a lot, and especially if this was a suicide attempt, there are going to be trust issues with the family. Does the family trust them to be safe? And there are lots of emotional issues with the family. They're relieved that they got a transplant and survived, but they may be they may be angry at the patient, and they may not trust them for anything. So I would ask questions about what they remember, help them fill in the blanks, but not overload them at the first time that they wake up.
That's a great observation. I'll ask questions from the floor. Well, I'm going to keep hammering here. Well, amnesia. I've seen it quite a bit, and I've dealt with all different aspects of it, and I always wondered one thing. Is some of the amnesia that they get selective, or is it always their brain damage from encephalopathy and the recovery, and then added with the ICU environment? Because I sense there is a little bit of denial usually that occurs when they realize they've committed such a bad deed, and some come to accept that, and then there is a kind of a separation of this is the past and this is the future, and I just don't remember. And you just can't tell whether you got to go along when they say I don't remember, or keep hammering it. Yes, you did. Yes, this happened, versus I understand, and move on to the positive phase. Mm-hmm. Does that make sense?
Mm-hmm. Certainly their first response may be, I don't remember. There's definitely parts that they're never going to remember, and it's a blessing that they don't, because they were really sick and their family wishes they didn't remember. But I think when you ask questions, what do you remember about before you came to the hospital? And we need to tell them, you took too many pills. Do you remember that? And then pull for it. But my team sort of sits down at the bedside, and we give them the time to work this through and talk about it. It may not be all in one sitting, but they do need to accept that, yes, they did do this, and what was the stress that led to it, and how can they find other ways of managing stress that are more effective and more positive. So we don't want to just sweep it under the rug, but we don't want to batter them with it either.
Are there support groups for such patients, or do they go on individual therapy programs?
There are support groups for suicide attempters. There are depression groups. Individual therapy is necessary. Some people benefit from antidepressant medication as well. However, some people, when they come through this, look back and they realize, you know, at the time I thought this was a life or death issue. I didn't think life was worth going on after this breakup with a boyfriend or whatever. But, you know, this whole thing has put my life in a different perspective, and they're looking at it in a different way.
Yeah.
But therapy is important to work through that
Sure.
and be able to put it in the past,
Yeah.
and to be able to help their support system regain some trust, that they don't have to watch them like a hawk.
They would have to reframe their mental and psychological energy.
Mm-hmm.
One last question, I promise. Suicide in acute context, a lot of times it's an adjustment disorder, whether it's related to circumstances or context or whatever. Does the transplant induce another adjustment disorder that gets impacted with compliance to taking medications subsequently? So instead of having the original events or circumstances that created that adjustment problem, now you have another event that created yet another one, especially with the burden of long-term care, medications, insurance, co-pays. Their life has changed. Mm-hmm. How does that impact their compliance to take meds and re-engage with their care?
It sort of reminds me of Tom Starzl, who's the father of liver transplant, had a quote that stays with people, that liver transplant is the ultimate sobering experience. And he believed, early on at least, that alcoholics or people who are using substances, having a liver transplant itself would make them never want to go back to drinking, because they had such a profound experience. And for some people, that's true. That's also true in the context of liver transplant can certainly realign people's priorities and change the way they're looking at it, and they may not be suicidal anymore. But we can't count on that, either in the case of substance abuse or in the case, we can't just count on you've been through a major life event, so you are thanking, you know, whoever you thank that you've survived and you're going to make something different of your life. Some people do that spontaneously and some people don't.
Yeah. Got it. Caroline?
I think that's when it becomes really important to help the patient really identify what are going to be the motivating factors for them personally to now adapt to this new life, these new things they must comply with, and really in terms of their personal motivation, how can they do that in the best way possible?
Yeah.
Which, you know, it does take some time, and I think that's something we're able to help them with when there has been such a significant shift.
Sure. Yeah, especially them not feeling that they're alone anymore. I think there is a community of transplant recipients and staff that may help them. Question of Denise?
Yeah.
Denise and Mike? Yeah.
Go ahead.
Yeah. Denise, you were first. You raise your hand first.
Kind of startled or curious about the idea of selection having to do with, beyond a treatable disorder that would lead to suicide, the equity of considering whether or not a person did this to themselves. Considering we transplant for so many diseases that people did this for themselves, smoked up to like the month before they were considered for lung transplant, or poor control of their diabetes. Is this really a prominent part of the selection process in general, not necessarily here, but in general, in my awareness that the patient did this to themselves?
It's something, when there are ethical discussions in the literature, those kinds of things come up as far as somebody's worth, or, you know, should we be treating people in the emergency department who didn't wear helmets and got in motorcycle accidents. But always the bottom line after that discussion is we have a responsibility to take care of people regardless of if they caused it themselves.
Yeah, I always think that we are healthcare providers, not judgmental healthcare providers. Denise?
I was wondering how CMS would look at the recipient who's unable to give informed consent. How do they treat that? You know, have they,
Well, a surrogate makes the decision,
Yeah.
so the family would have to sign for the procedure.
Yeah, there is typically a fair number of rules and policies on surrogates or next of kin and things like that. What our group in general, I mean, healthcare providers in general, have to battle with, besides the likelihood of committing suicide again, is if the social systems are weak, to where even that surrogate or the family are not close enough to be the surrogate and are not tight enough to provide support systems. And you know this is a young person who may or may not have committed the act if they had known they'll be so effective at doing it. Because sometimes it's an attention-seeking behavior that they do. So this is where I find really very difficult scenarios where you know it was foolish, they didn't think it would happen, it did happen, and there is no good surrogates, yet they are the next of kin, and you know they're not going to be there when they're needed. And I think we've had situations like this where
That's very hard.
we did not go through the delivery of a transplant because you're effectively saying life is going to end, and even though we can try to salvage it, it's futile. And it's not going to be an appropriate use of a scarce resource. It will be wasted again. Wow, that's a tough one. And I think that's probably the complex scenario here. What do you think?
One thing, just following up on Mike's question, I gave a version of this to psychiatry grand rounds a few months ago, and one of our psychiatry residents was sitting in the audience, and she was a very good friend of a gentleman who was on our waiting list, desperately needing a liver. And she said, you know, this is really tough because is it fair that we should give this person who attempted suicide or overdosed unintentionally when my friend, through no fault of his own, needs a transplant and may die? And, you know, it was interesting discussion.
Yeah, well, the thing that's amazing is how many times we always say no fault of your own, when actually there is tons that are faults of your own along your entire life journey. And if we ever open that door, life or fault of your own, you will find that you're not entitled to a lot of things that you get, whether it's a job or whether it's pay, whether it is whatever compensation. And that's why I think that ethical debate of fault of your own starts not at the time when you get overdose or you get overweight. It starts way earlier than that, and it doesn't end. And so I think that we have to be very careful with that debate if we ever get there. I know that we were going to go there in some level, some direction, when cost of healthcare becomes so high that we just can no longer afford it. And I think what's going to happen is, in my opinion, is those who will drive costs more through things they can influence will be asked to pitch in more than others. Is that the right answer? I'm not really sure with that either, because that brings in those with more wealth and against those with less wealth as well. Where does the value system lie? I think somewhere between here and there. But okay.
One more question?
One more question.
So what's been your experience with the patients that you have taken care of who've had transplant due to overdose, whether it was suicidal or not, in terms of their dealing with improving their quality of life and addressing the underlying issues that got them to that place? So post-transplant, do you find that for the most part, are you seeing that people are committed to dealing with the underlying problems that brought them to a suicidal attempt or abuse of drugs?
There's really variability, and that's hard to say. There isn't any specific literature that goes into it in that kind of depth, and I haven't really looked at it in our series, so I don't really know. But I think there's a variety of responses, so that some people do want to, you know, sweep it under the rug and not think about it. But it is important to understand what led to the transplant and to be able to leave that in the past and move on. And some people have a response after a traumatic event like a transplant, where they decide to take a new turn in their life and develop things in a positive way, reconnect with important people. There's a concept of post-traumatic growth where people actually go beyond what they would have gone because of the event. So we see that sometimes too, but it's really all over the map. The ones that I worry the most about are the ones with substance abuse histories, because it's very important to treat the substance abuse and maintain abstinence, and that's very difficult. Well, thank you very much.